Hello, ladies and gentlemen. My name is Robert Landewé. I am a rheumatologist working in the Amsterdam University Medical Center, as well as in the Zuiderland Medical Center in Heerlen, which is a place in the south of the Netherlands. And I'm here to talk about axial spondyloarthritis, the disease spectrum, and in particular some priorities and challenges that this disease spectrum conveys. Here are my potential conflicts of interest. As you may imagine, I've worked with most of the companies that have developed treatments for ankylosing spondylitis and non-radiographic axial spondyloarthritis. But I'm also the past president of the ASAS organization and the current ASAS board member, and I run my own company which is involved in reading X-rays and MRIs, among others for axial spondyloarthritis clinical trials. Before I start my presentation, I think I have to make three confessions here. The first is, regardless of what I'm going to say in a minute, I do believe in the existence of patients with non-radiographic axial spondyloarthritis. But I think axial spondyloarthritis is a better term than non-radiographic axial spondyloarthritis. It's also a better term than the old-fashioned ankylosing spondylitis. And my last confession before I start my presentation is that I indeed, regardless of what I'm going to say, do believe that biological DMARDs and probably also some JAK inhibitors are effective drugs in patients that have real axial spondyloarthritis. So when I'm going to talk about axial SpA and treatment and finding the proper patients, which challenges do I see nowadays? Well, the first obviously is that you should get the right patient before you start an expensive drug, a biological drug that also has potential side effects. And the second thing is that you should measure the right thing, the right disease activity measure, not only in order to see whether a patient will be included in it, not in a trial necessarily, but put on a drug, a biological drug, and that you use the right measure to measure if that patient indeed improves over time or not. Much of the data that we use all day in clinical practice when patients come into our office is data that is derived from so-called randomized controlled trials. And that is not easy stuff because we have actually many different kinds of randomized controlled trials, and it is very difficult sometimes to bake cake out of all those clinical trials. So you may wonder, what is wrong with the current trials that we look at? Well, nothing in terms of internal validity. Internal validity means the rigor, the robustness of a clinical trial. Those trials are pretty good. They actually measure what they intend to measure. They also are very good when it comes to effective drug approval. In fact, RCTs are often done in order to get a new drug on the market, and it works pretty well in that regard. But we can learn a lot more when it comes to interpreting the results of clinical trials into all-day use, the use into patients that we have to treat in our office that come in with axial spondyloarthritis. So the problem is, are the right patients in the trials and are the right outcome measures used for these trials? And that is important because in the end, you have to make a decision in your individual patient that comes into your office whether or not to start a biological drug and how to measure whether that drug is effective. If we are talking about ankylosing spondylitis, then you are all very much aware of the so-called typical ankylosing spondylitis patient. Here is a picture of a typical ankylosing spondylitis patient in its end stage. It's typified pretty well by the modified New York criteria. No one will doubt that this patient indeed has axial spondyloarthritis or ankylosing spondylitis. The only problem here is that you are 20 years too late when the patient enters your office in this particular stage. You should have been far earlier than you are now. When you want to see that patient earlier, then you have to be aware of how an early ankylosing spondylitis patient looks like. So here is a so-called narrative, a story of a patient with early ankylosing spondylitis. A young man was developed inflammatory back pain, knee arthritis at the age of 22, which is not more than 2-3 years ago, reports a father with Bechdrev's disease, ankylosing spondylitis. On examination, has impaired lumbar mobility, and you test him positive for the antigen HLA-B27. You make an X-ray, and the X-ray that the patient produces looks like this. This is clear-cut radiographic sacroiliitis. You could say this narrative together with this X-ray represents the early gestalt, the early pattern of a patient with ankylosing spondylitis. Many patients ask me, well, what is the narrative of a non-radiographic axial spondyloarthritis patient? It's not so different. In fact, it is exactly the same story as the patient with ankylosing spondylitis in an early phase, except for one thing. If you do the X-ray in this particular patient, it turns out to be negative, and if you replace that by an MRI, you have a pretty high likelihood that you find this picture, a so-called MRI positive patient. There's bone marrow edema in both SI joints as a sign of early axial spondyloarthritis. This is the gestalt, the typical picture of non-radiographic axial spondyloarthritis. You may wonder, when you look into ankylosing spondylitis trials, especially the earlier ankylosing spondylitis trials, how patients that are in those trials get into those trials. Well, essentially, they need a diagnosis of ankylosing spondylitis, which is on the investigator's opinion, and they need a positive X-ray according to the modified New York classification criteria. And the most prominent feature of a diagnosis of ankylosing spondylitis when it comes to clinical symptoms is the presence of inflammatory back pain. So basically, inflammatory back pain and the positive X-ray make a patient eligible to that trial. What is the problem here? Well, the problem is twofold. First, inflammatory back pain as a clinical sign is definitely not a reliable symptom in a world full of patients with chronic back pain. And the second problem is that bilateral grade 2 or unilateral grade 3 classification, which is something, and you know that very well, that you need for a positive modified New York X-ray, that those findings are highly irreproducible. Is it a real concern? Well, it is. If I take an X-ray, a pelvic X-ray of a patient, and I show it to reader 1, and it is this particular X-ray that is more or less equifocal, then you have a high likelihood that reader 1 says, well, this patient is modified New York positive, and I take that X-ray and bring it to a second reader independently of reader 1. That reader may say, well, in my opinion, this is modified New York negative. If you do that with a set of hundreds of pelvic X-rays, which is something we have done a couple of times in the past, you can calculate the level of agreement, or the kappa, and it turns out that the kappa is not more than 0.40. That means moderate agreement at best. Does this phenomenon hinder the results of clinical trials? Well, maybe not the general results, I come back to that a little bit later, but at least it tells you something about the patients in the trials. We have found that up to 40% of patients offered for inclusion in AS or non-radiographic axial SpA trials are actually rejected after central reading of pelvic X-rays or MRI. What does it mean? Well, it means that the local investigator thinks that the patient is eligible for a clinical trial, but the central readers reject that particular patient for the trials. Effectively, they say, well, this patient does not have ankylosing spondylitis or non-radiographic axial SpA. When we reread patients in AS trials that have been done with approved drugs, there was image misclassification in up to 30% of those ankylosing spondylitis trials. Or worded differently, in all those trials are many patients that in the end may not have the disease that you want to treat them. You may say, well, why bother? In fact, in the end, all these trials that we have done with biological DMARDs and nowadays sometimes with JAK inhibitors have always clearly separated between active drug and placebo. And in all those trials, if you look in this particular figure, you see at least 40% symptom reduction in at least 40% of all the patients that have been included, which is effectively true. But you shouldn't forget that we're talking about average results. And this is important. Let me go through this particular slide. Assume that we have a clinical trial that consists of 50% patients with real ankylosing spondylitis. And of those real ankylosing spondylitis, we expect a high chance to respond on the drug that we give. And for the other 50%, they consist of ankylosing spondylitis lookalikes, fake AS if you like. In fact, because these patients have not AS, they are not supposed to respond on a drug that improves real ankylosing spondylitis. Then you give the drug, and you see that those patients with real AS importantly improve. And the entire spectrum of real AS patients moves to the right. The fake AS patients, however, don't respond at all. They're not expected to respond, so there is not a lot of movement over here. But because of the excellent response of the real AS patients, the average effect indicator moves to the right. And you do a little bit of statistics on this, and you find a highly significant p-value. Your paper appears in the New England Journal of Medicine, and this particular drug will be prescribed to every patient that looks a little bit like the patient in the trial. Is there any indication that this phenomenon takes place? Well, there is. When we look back into trials, it is very obvious that the patients with increased CRP respond better to the drugs that have been tested. It's also very obvious that the patients with a positive MRI at baseline also respond better. Well, what is increased CRP? What is MRI positivity? Those are both indicators of the presence of inflammation. So if inflammation is present, patients can be expected to respond on an anti-inflammatory drug, which makes sense. However, if you look in the trials and if you sort of transpose that to clinical practice, then the world is made up of patient-reported symptoms rather than of objective measures of inflammation. And the modern trials that we have and that you use to derive your evidence from when it comes to starting a biological drug or an anti-inflammatory drug in a patient with axial spondyloarthritis, that world is made up of patient-reported symptoms. So here's my first recommendation. It says make sure you put the right patient in the SpA trial, but you can easily translate that with make sure you choose the right patient before starting a biological drug or a JAK inhibitor. It comes back to education. You should know as a clinician what real axial spondyloarthritis truly is. It comes back to enrichment. What does it mean? Well, make sure that if you decide or consider to start biological DMARDs or JAK inhibitors in patients with axial spondyloarthritis, that you enrich them with a lot of evidence for inflammation. Make sure that you have an inflammatory patient. And objectively check. Don't believe your own judgment when you look at an X-ray or an MRI. Go also to a colleague and ask him or her to objectively check whether your colleague finds the same as you find. So that brings me to the second part. Make sure that you use the right disease activity measures. And the disease activity measures that you see here in order to determine the status of disease activity or determine the response to treatment of a particular drug. Those are the measures that I mentioned here. You're all familiar with BASDAI, back pain at night, which is an important entry criterion in many clinical trials. And when it comes to response, we have the ASAS response criteria and also things like ASAS partial remission. The problem, so to say, with these measures is that they are fully patient-reported. Why do we use them, you may wonder? Well, PROs are required by the agencies. It makes sense. If you don't improve symptoms of patients, you don't have a good drug. That is a useless drug. And they are actually approved or used under the assumption that they reflect the pathophysiological process of the disease. And the pathophysiological process underlying axial spondyloarthritis obviously is the presence of inflammation. We assume that inflammation causes the symptoms that we want to treat. However, when you do investigate the relationship, the association between objective inflammatory measures of axial spondyloarthritis on the one hand and patient-reported outcomes on the other hand, you see the same problem as with the X-rays. The kappa, the level of agreement, is only 0.50, which is moderate at best. Let me explain what this means. If you look at all the patients that come into your office with an indicator symptom, an indicator presentation, when it comes to axial spondyloarthritis, 9 out of 10 times that is pain, back pain associated with stiffness, with fatigue, with general malaise, etc. You should realize that there is a gradient of increasing inflammation. What does it mean? Well, many of the patients that come in with pain and stiffness actually do not have inflammation. But along the line, there's patients with a lot of pain and little inflammation versus patients with increasing levels of inflammation. That is what I mean by gradient. And we know from the forma that the more inflammation there is, the higher the likelihood of a clinical response is. So when it comes to measuring disease activity, how should we do that? Well, it is very important to combine information on subjective as well as objective outcomes. And eligibility, that is a word that is used in clinical trials, but also the decision to start a biological DMARD should be based on this combination of outcomes, subjective and objective outcomes. And the primary outcome in a trial, or the primary decision you have to make whether a particular drug works in an individual patient, should be based on this combination of subjective and objective outcomes. So here's my second recommendation of the day. Make sure you use the right measure to decide whether a patient should be put on an expensive biological DMARD or not. And for that you need PROs and inflammatory markers, CRP, MRI. That is not only for starting a drug, but also for determining after some time whether the drug is effective or should better be stopped or changed into something else. So I come to a summary of my challenges and priorities in the field. I think the average findings in modern clinical trials do suffice for new drug registration. But when it comes to generalizability, to interpreting data into clinical practice into individual patients, the trial results fall short. The average patient with axial spondyloarthritis, but also with rheumatoid arthritis or whatever, the average patient does not exist. You have to deal with an individual patient that's sitting in front of you in your office. And you should make sure before starting a biological DMARD that that patient sitting in front of you really has axial spondyloarthritis. That means really has inflammation. You should measure and follow those patients with the appropriate measures that combine subjective and objective inflammation. I didn't want to talk too much about ASDAS, but ASDAS is indeed an ASDAS-approved measure for disease activity that combines patient-reported outcomes with an inflammatory marker such as CRP. So, in order to keep it simple, I would recommend two things. The first is, when you consider starting a biological DMARD in a patient with axial spondyloarthritis, first make sure that you select the right patient, that is the patient with inflammation. Second, use the right measure to measure that patient and to follow that patient over time. Thank you very much.
Dear Robert, do you think that the world of axial spondyloarthritis moves to treat to target?
Yeah, I presume what is meant by this particular question is whether we will use the concept of treat to target more frequently in the context of axial spondyloarthritis. The answer to the question probably is yes. I'm not 100% sure, though, whether this is a really good movement, so to say. The problem with treat to target in a world in which we have many different drugs available for treatment is that you do not measure properly whether your patient indeed has improved, and that, for instance, the presence of treatment resistant patient reported symptoms like back pain and fatigue and general well being, etc., move you toward intensifying the treatment, where this is not a good thing to do. For the simple reason that if you have a patient with a lot of symptoms but with very little inflammation, there's not much to expect from treat to target with more and more intensive biological DMARDs or whatever we will invent in the near future. So I'm a bit afraid that moving too much into treat to target will move the field into the wrong direction, and we have to be very careful with that. When it comes to really inflammatory patient, it makes sense, I would say.